I'm really excited to have Aaro here. His work sits at the intersection of science and technology studies and biomedicine and data governance. And that's part of what we'll be touching on today also. And he's explored for several decades now, I think, how biobanks and health and data infrastructures are built and managed. And also politicized, both as national resource, but also as global data commodities. So I'm really excited to hear more about your ongoing work from the Finnish perspective, I believe, today. So please welcome Aaro.
Thank you very much, Mette. It's been a really wonderful few days here. Yesterday was a really nice day, a very special event, and we had a really nice discussion. Today sort of rounds that off, I think, really, really nicely. Thank you also for extending the invitation to come and talk here. It's a really great opportunity, I think, to share ideas and also some of the work that myself and my colleagues have been working on, not just in Finland, but also in Denmark and in Norway. Just a bit about myself in terms of my background. So I'm a sociologist by training, but I think I lean quite heavily into the STS genre myself. And quite often I find myself in Finland, sociologists asking for me, is this sociology? So, but this is, I think, a common issue that takes place. As Mette said, I've had a long-term interest in biobanks. And it started already when I was doing my master's degree and so forth. And it has sort of ballooned and continued along those lines in different ways, looking at biobanks as ways of organizing materials and data, but also facilitating research. And what kind of preconditions are required of that process and what kind of consequences also it might have for daily practices in research and in general. And I've worked both in Finland and I've had the unique opportunity. We lived and worked in Denmark for 5 years. I worked at the University of Copenhagen with Klaus Højer and his colleagues. And so I will have I've sprinkled a bit of Denmark in here just to make these connections as well. And I think that's a really important aspect of the work that I have been doing and that we're trying to do, where we're trying to do more comparative work in terms of looking at not just Finland, but also the other Nordic countries, and more looking at Europe in relation to the European health data space. And that's what the title of the talk today refers to, experiences from Finland in relation to the EHDS and maybe some cautionary tales, if you will. And like I said, my more recent work has then shifted more and more to look at the data aspect and the health data aspect in relation to biobanking, because at least in Finland, that has been a major push, but also this also relates to the EHDS more and more. Secondary use, sorry, I'm finding these spelling mistakes as particularly today I'm going to be talking about the secondary use of health data and the implications that it has in terms of more the European context, but also I'm going to maybe tie it a bit also to the Danish context as well. So first, I think we need to talk about sharing and the idea of sharing within the scientific realm. And in the general sense, I'd say that sharing has both this sort of normative dimension to it, as well as, at least within Finland, and I would argue also in Denmark and within the European context, more and more of an economic dimension as well. So the idea of open science, that the data that you produce should be made available to others, that has a very strong tradition within the sciences, Merton and so forth. Now, of course, within STS, we also have a huge amount of literature on these counter norms of why scientists also hold on to their data or don't want to share, and there's a lot of really important and interesting literature in that. However, if you look at the policy field right now, there's a very, very strong push towards open science, sharing data sets, and so forth. And in many ways, I do support this. I think it is a very important sort of aspect of science, and it needs to be supported and developed further. Increasingly, however, if you look at policy documents in Finland, but also within the European Union, there's also a very strong economic or innovation push in terms of what we expect from this data sharing. Now, of course, this is where value gets generated. In some ways, we can talk about value in many different ways. Scientific value, we can talk about the health value, that there'll be new types of treatments and diagnosis for people, but also the economic impact of making money, making business, that businesses then sell various services and products and so forth. And this is increasingly present in policy document. However, in a lot of the work that myself and my colleagues have been doing, we can't help but notice that there is a huge heterogeneity of data and the context that it's shared in, not or also collected in. And it's not always obvious what conditions sharing should take place in or how it should be implemented in practice. Now, obviously, in terms of this open science, there are a lot of different types of projects that are going on to share data within different domains. So the health data in this sense only constitutes one rather specific domain with its own uniqueness and so forth. So in this sense, we can ask, what does sharing require from all these different actors who are part of it, but also implicated in it? Some are more willing and some are less. And one of the observations that I've made is there seems to be a rift between policy or practice, or at least the policies related to this aren't necessarily supporting the open science maybe enough. And I'll get to that towards the latter part of the presentation. So why look at the Nordic countries? Well, the Nordic countries are rather unique, and I'm sure you've seen and heard about this many a time ad nauseum, perhaps, but let's go over again. There is this sort of Nordic exceptionalism that we talk about. How many of you have seen this picture before from the Danish National Biobank? Yes, good. Charlotte, I was expecting the hand, right? So this is, I think, a quote from Lone Frank, a Danish journalist who wrote at least in my world, a famous article about Denmark being the epidemiologist's dream. And I think in many ways, the Nordic countries share many of these facets together, right? We have the CPR number, healthcare registers, data linkage, welfare state, and so forth. And in this sense, the Nordic countries are also very different from the rest of Europe, and especially the rest of the world. And so in this sense, I would agree that there is this sort of Nordic exceptionalism. And I've written a book called Populations and Brands, where I also look at Denmark and Finland and policies related to sort of marketing the population and data from the population or samples from the population for this sort of economic or business tilt. I just realized I've stolen this slide from someone at Aarhus University. But these types of slides, this is from Denmark, this is from Finland, this is from Business Finland, and so forth. But if you go through policy documents or various types of PowerPoint slides where people talk about this Nordic exceptionalism, you will get almost verbatim very similar things. This is not exactly the same thing as this, but I just didn't find right now an exact copy of this. But in Finland, we have very much similar things, advertising the same things. And in Denmark, you also have very similar things. The only difference, I think, that in Finland, usually in our slides, we also have the Aurora body that we like to, or Santa, or something like that, something very quirky or so forth, to make us stand out. But this is sort of part and parcel of the marketing, if you will, or the sale or the pitch of why come to the Nordic countries. And I think I don't have any particular qualm with this. I'm just pointing out that in the Nordic countries, when I come here, the Danes are doing it. They just have a Danish flag. When I'm in Finland, the Finns are doing it, and we just have, you know, the Aaro there, or the Finnish flag, or so forth. And I think you could see the same thing maybe in Sweden or Norway, but at least in Denmark and Finland, I think this is the most salient feature that I've seen. And so, given these features, we've had interest with colleagues from Norway, Hydronom, and from here in Denmark, Lodekroth Jensen and Rasmus, Milgaard, that's it. And then my colleagues Karolina Snell and Heta Tarkkala, to think about what kind of things or what kind of features are similar and different within these three countries in terms of making data available. And one of the interesting findings that we note within this article that we recently published was, despite all the marketing and the hype of the Nordic countries being the best place for doing this research, we're very, very different, surprisingly different. And we have different strengths and weaknesses. And these strengths and weaknesses and differences come or have come about from different historical trajectories of how data has been collected, by whom, and how it's being maintained, right? So the various organizations that collect data, they have their own sort of politics around it. There are very many similar organizations, Statistics Finland, Statistics Denmark, is it? Yes, very similar, right? But then there are also a lot of differences between hospitals, for instance. And once you start getting into different types of health data, you really notice the differences, as well as you do in terms of the practices of what conditions are required in order to get access for that data. And this has given rise to different types of sharing practices. And within this context, we have the EHDS. So everything that's related or going on at the European level in terms of the European health data space. This comes, in a sense, I would say, from the top with the involvement of people in the field to try and align these various types of practices, right? And our observations within the Nordic countries have been that the Nordic countries are going, oh, okay, yeah, we are very, very different. But I've also been to conferences where they're developing, like Tehdas 2, which is a joint action where they're trying to sort of develop the EHDS, where I've been sitting next to people from Croatia, and they've just been shaking their heads and saying, we have none of this. We have none of that, what you're doing there. What are we going to do in 2 years when this is supposed to be happening, right? So the differences exist not just among the Nordic countries, but also within Europe as well. And this is also, I think, a major challenge with the EHDS in how this is going to take place. Good. So then a bit about the Finnish context and where myself and my colleagues are coming from. So we decided a few years ago with Ilpo Helen, Karolina Snell, and Heta Tarkkala that we had to write a book in which we brought together all our work that we had been doing over the decades on genomic research in Finland and tell a story. And it's a story. There are other stories as well. But it's a story of how Finland has gone from doing genetic research on rare diseases in the 60s and 70s to the current day sort of genomic research, high-tech medicine that is involved in sort of business, innovation policy, and so forth. And one of the observations that we make in that is how this model, which is being built up, particularly during the past 20 years, if you will, is being transcribed into different domains. I'm going to talk about that in the next slide. And how this belief of data from the population can be mobilized or should be mobilized to create all kinds of new innovations, treatments, and so forth, but also wealth, if you will, an engine for economic growth. And in order to do that, you have to mobilize certain types of activities within the government apparatus. And for Finland, the main tools have been, at least thus far, the Act on Biobanking and the Act on Secondary Use of Social Welfare and Health Data. And the Act on Biobanking came into force in 2012. And they'd started talking about this already in 2006, 2007. We were involved in research projects where we were doing surveys of how do people feel about their samples being put in a biobank and so forth and so forth. But it took several years for them to actually come up with an act that everybody agreed with. And the main gist of it was that there was an establishment of biobanks as an institutional entity that had a legal status and so forth. And so currently we have the Finnish Biobank Cooperative, which is made up of 8 member biobanks, 6 regional hospital biobanks, the Arctic Biobank, and the National Public Health Biobank. This probably has the biggest sample collections since it's sort of like Statens Serum Institute and the Danish National Biobank. They have all the long-term cohorts and so forth. And then there are also 2 network biobanks, Blood Service Biobank and this is the hematological biobank. And then 1 private collaborator biobank, Terveystalo, which their collection is rather small from what I understand. And then, another one. And what you do is, in order to get access to these or find out what's going on, then you go through the FinGenius portal. And the Danish National Biobank also has its own portal, and you can go there and search for samples and so forth, and then you can request the samples and so forth. The idea was that you can get everything in one place, right? So it's a simple, easy access point. The original idea was that Finland would have one big biobank, but all of these actors said no. We're not giving our samples to one big biobank. That would probably be in Helsinki. It would take all the money, all the resources, all the know-how, and so forth. So they ended up with a sort of hub and spokes model where FinBB is this cooperative that everybody is a part of, and then they have one single sort of portal which they maintain and they update their catalogs and so forth to that. This idea was then transferred, in a sense, to Findata. And the idea is that we need legislation, like the Biobank Act, that will apply to social welfare and health data, right? And so what this act did was it established Findata, which is the Finnish Social and Health Data Permit Authority. So if you want data from the various health and social welfare catalogs, then you go to Findata. You go on their website, you log on, there's a whole process. However, if you want data only from one data controller, you can still go to that specific controller. Sorry, I'm losing my voice. But if you want to combine data, then you have to go to Findata. And what Findata does is it then gets the data from all these different registers and it deposits it in a secure computing environment where you can do your analysis. And then when you want to get stuff out of there, Findata checks it out and makes sure there's no personal data or no identifier data. And then you can do your analysis there. Now, these are the biobanks that are involved in this, right? This is what you can access through Findata. So I think I counted 14 of these. Now, if you click on these, for instance, public social welfare and healthcare organizers, this will expand to all the organizers in Finland, right? Or the regional state administrations, or Statistics Finland. They have dozens of different type of data sources. Finnish Institute for Welfare and Health, or Health and Welfare, sorry. Yeah. So there's a huge amount of data that you can get access to. And I'm not going to go into the minutia of all this, because some of these actors like THL have given Findata the right to give out their data so they don't have to go to them and so forth. But this is the major sort of thing. So Findata and the Act was much more broad and encompassing than the Biobank Act, but that model was then transferred. And in many ways, this model for data access is also the model for the EHDS in some ways. And we'll get to that also in a second. But the idea of this is to have a one-stop shop, right? And I think it's a good idea. Instead of researchers having to go here and there and having to find, you just go to one place, right? If you're interested in biobank samples in Finland, you go to FinGenius and you look in the catalog, what they have, and you get access to it. In Denmark, you go to the Danish National Biobank, and you get access to a lot. Maybe not eyesight and stuff like this, but still, you know, Denmark still has some tensions between various collections, if you will, but we won't get into it. But the idea is to have this one stop where you can go and get access to everything. Now, what this requires is a clear description of sample or data availability, and this sort of highlights the centrality of these catalogs as well as the metadata that's associated with them. But you can imagine that if you're one of these organizations and you haven't been doing this for a long time, then it's a huge job to start describing all the different types of data that you have and what's in them, right? If you're a hospital, for instance, and you're used to just doing primary care, right? And now there's a law that says, hey, you've got to share this data. They're like, oh, all right, where are we going to get someone? Are you paying for this? No, we're not paying for this. So it's a huge challenge for some organizers or some actors. And it quite often requires tacit knowledge of data itself. So it requires a specialist skill, right, in data work. So someone has to know what's in that register, why it is like that, how long has it been like that, why are there these sort of quirks in it, and how do you describe it to someone who's asking for it, right? And this is the knowledge that Findata didn't magically acquire when the law was made and when Findata was established. And so, like I said, this is the model that was developed in biobank and then copied in health data. And now also, I think it's being transferred into the EHDS. And the reason why I say this is all of this in Finland relates in many ways to the central role of Sitra in facilitating this vision and model of data sharing. What is Sitra, you say? So Sitra is the Finnish Innovation Fund. Finnish Innovation Fund. And this is a government-funded think tank. And currently it's very, very involved in the development of EU policy through various projects, particularly Tehdas 2 and Valo. And Tehdas 2 was preceded by Tehdas, the original one. And this all has to do with data sharing within the EU. And it plays a major role in developing the foundation of the EHDS. And a lot of the things that it is developing and working on within these two contexts have been learned and developed within Finland, within biobanking, and within the secondary use of social welfare and health data. And so that model is being sort of pushed within the European context. And so what I wanted to do for the last part of the talk was describe some of my work that we're doing right now related to this. And this is based on interviews that I've been doing with Findata and various actors who provide secondary data. So I've been doing interviews with Findata experts in different registers, as well as policymakers, and also looking at policy docs and legislation and so forth. And we're working on an article with my colleagues Heta and Karolina that tentatively is entitled Infrastructure Work in the Finnish Health Data Space. And I'd like to particularly look at three observations that we sort of highlight within this text. The first one relates to the relocation of data work, or what we call looping. And this is also actually in the other article with Heidrun and colleagues. Then I want to highlight data work capacities, or the lack thereof, as well as finally the ambiguity in value generation related to this. So the first one relates to the relocation of data work. When Findata was originally established, it was very clear from the outset that they did not have enough resources to manage all the data requests that they were getting. And research all but stopped just because researchers could not get access to the data, right? And quite often they lacked the tacit knowledge of many of the registers. So when someone would put in a data request to them, they would then have to forward that request via email to that various register keeper. Some of the register keepers would have the answer very quickly, right? Some, it could take 2 to 3 months just because they had no person who had been given this task. So there was an email bouncing around a hospital and no one really wanted to catch the hot potato, if it will. And one of the weird quirks of this system was that even when they were managed to get all the data, or they say, okay, everybody has it, the researcher couldn't access it in a secure computing environment until the last data was deposited in there. So let's say you requested data from 5 sources. 4 had come, but you couldn't access it until the 5th had come. And this was a major change in the sort of workflow for researchers, where usually the researcher would go to all these different data registers, request the data, then the data would start coming in, and because it would be on your own computer, then you could already start sort of going through it as it came in. Now, I think the idea of having data in a secure computing environment is very good. It complies with GDPR. We don't want personal data, sensitive data, bouncing around on researchers' personal computers and somebody loses a laptop and someone finds it or so forth. So in that sense, I think it's a good process, but it was implemented too quickly and there weren't enough resources neither at Findata or at many of the data registers. In addition, the data catalogs weren't complete or they were poorly described. And so there kept being this back and forth between Findata and the registers, which also added extra time. And for some very interesting reason, the data could only be deposited in secure computing environments that had been audited by a Finnish company, right? So Findata doesn't have the only secure computing environment. THL has its own, a number of hospitals have their own, but no Danish research group or Statens Serum Institute would have their computing environment audited by a Finnish company. So this meant international collaboration, all but ended, okay? And this is still an issue. And this hopefully they will be addressing within hopefully a revision of the secondary data. And so Findata obviously and the law received a lot of criticism from researchers. First, it took a lot of time to get access to data. And second of all, they couldn't share data with their international collaborators. Okay. So one of the ways that Findata then resolved this was they provided new instructions for researchers that before they came to Findata, they should go to each of the registry keepers to ask them about the data itself, right? Do you have this data? Can you describe it to me? And so forth, tell me. And so they had to do that before they went to Findata, right? But the problem is the idea of the one-stop shop went back to this many stop shops idea. And so you had this looping. And so this relocated the work that the researchers had been doing back to them, right? Even though Findata was supposed to take care of this. And what this has then also meant is that you have a number of various actors in Finland who are saying, well, come on, why can't we also be a data authority? Couldn't we have multiple authorities? Which technically you could, but then the idea of having a single entry point for data access then just goes away. Now, what's going to happen, it's unclear, and how this is then applied elsewhere in Europe, I'm not sure, right? And so there are many calls for revisions of legislation to allow for multiple data providers in Finland. Okay. Then the second point relates to data work capacities. So the law exposed differences in the capacities of many of these registered keepers. Some of them had decades of experience of sharing data. And they had teams of it, experts who knew exactly what was in there, THL being one of the examples, or the Finnish Center for Pensions, right? You go on their website, they have a team of people who do that. You send in a request if you're just getting data from them, and within 3 to 5 working days, you'll have an answer, right? It's a well-oiled machine. But like I told you, hospital region of Lapland, they don't do a lot of research collaboration. Yes, they have doctors who do research on their own data, but they're allowed to go in there and do that. But they don't have a team that answers requests. And then if you add insult to injury, Finland is going through major cutbacks to its healthcare sector. So the hospital regions are having to fire a lot of nurses, doctors, cut back on services. And at the same time, this law requires them to provide secondary data for researchers from wherever, right? So it's very hard for them to allocate resources, or at least in any way develop a service that would be efficient and actually meet the ideals, if you will, of data sharing that would serve the interests of researchers. And so one of the problems of this law was that it didn't take into account how resource-intensive data work is. That you need to have people who maintain it, who curate it. I don't know, has anybody heard of OMOP? No? Okay, well, look it up. But it's a way of mapping data resources and connecting, and a lot of hospital regions are doing this OMOP process, so it's easier to sort of say, okay, I'm looking for data like this, and then you have it like that. But that requires work. That means that you have to allocate people to do that labeling work and identifying it, and have that sort of hands-on knowledge of what kind of data there is. But there hasn't been investment in this. And particularly in this context of cutbacks into healthcare, it creates tensions within certain sectors. Then finally, I want to talk about this sort of ambiguity in value generation. As I said at the beginning, this norm of data sharing is, I think, great, and I do support it. But it doesn't also have a clear vision of how value is to be generated within this model. Okay? So, particularly if we think about the emphasis that is placed on this sort of economic and the innovation aspects, right? How is value generated within the Finnish context? To be blunt and sort of quite selfish. So the current access models don't necessitate any type of responsibility or requirement for collaboration, investment, and so forth. Right? So you could be a Danish researcher, a Spanish researcher, and you go to Findata, get your data, get your samples, do your analysis, get the data out, and Finland doesn't have to hear from you again. Right? You can start your business in Spain, or you can go anywhere in the world. US, Asia, any market, and you can do what you need to do. And nothing gets left behind, except for that service fee payment, which is nothing. So the question is, who benefits from this model? Do the Danes have it right? Because in Denmark, you have this idea that if you want access, then you're not required, but it's strongly encouraged that you have a collaboration with the Danish research group. And that's a good idea because that leaves something in Denmark, at least the scientific knowledge, the research papers and so forth. And so in that sense, I think you have it right. And then what incentives do hospitals have for providing secondary data if they get nothing in return? There's no incentive there. And is this a socially sustainable model? And so just finally, I want to sort of round this off with maybe this case and these sort of examples can provide some lessons also for the EHDS and what's going on at the European level, and which will also touch Denmark. So as I said, data work and tacit knowledge are key in facilitating efficient and meaningful sharing. But at the same time, you have to provide resources and capacities for this. And this requires long-term funding. And in Finland right now, we don't have any systematic way of funding this. Everything is sort of project-based. And this is a big challenge for the system as a whole. As I said, service fees don't sufficiently cover this, right? If you think about the long-term sustainability of hospitals and what hospitals do, their job is primary care. So the secondary thing needs to sort of fund itself, or it needs some sort of national support system to keep it going. So the hospital doesn't have to keep scraping from its primary tasks. Like I said, the Finnish model lacks effective incentives to collaborate and share. Are we going to turn just into data marts where anyone can come and just get the data and then generate the value, whether it be health or diagnostics, treatments or so forth, in whatever form, or financial? Do they just get located elsewhere where it's cheaper to implement them or so forth? And I think this is something that is not sufficiently addressed within the EHDS. And is it a sustainable model in the long run? And as I mentioned previously, I find it hard to believe that I'm saying this, that do the Danes have it right? Should there be some sort of incentive or encouragement for whoever is collecting the data to have some sort of interaction or collaboration with local researchers? Personally, I think this makes research more robust in terms of being done in context and involving those. And I think it will lead to better results. But at the moment, I don't see this type of incentive or thinking within the EHDS. And I think that's a problem. Okay, and I'll leave it at that. Thank you.